Hello everyone, this is Dr. Akif and we'll be talking about sepsis and septic shock today. So, sepsis is defined as a life-threatening organ dysfunction which is caused by a dysregulated host response. So, what happens usually is that when any other organism or pathogen enters into our our body immunity will try to respond, try to attack it. Sometimes what happens is that our immunity may not be able to correctly regulate that, and there may be a dysregulated response from our body. So whenever there is dysregulation response from the body, it will not only damage the microorganism, but it will also damage our normal healthy cell, and thus leading to condition called as sepsis, and thus affecting multiple organs. So for organ dysfunction, we use a score which is called a SOFA score, which is a sequential organ failure assessment score. So that SOFA score is this SOFA score involves 6 components involving each system. That is respiratory system, platelet counts, which is showing the hematology, bilirubin, assessing the liver functions, cardiovascular system, which is measured by using MAP or requirement of inotropes, central nervous system, which is assessed by GCS, and the renal system, which is assessed by creatinine and urine output. So all these parameters we use to assess the SOFA score. So what we have to do, single reading is not of much importance. First we measure someday, and then sequentially every day we have to keep monitoring and recording, keeping a track of that. And then if the SOFA score, if you see an acute increase in SOFA score of more than equal to 2, like that score, if it is increasing by more than 2, that means there is a severe organ dysfunction has started. And whenever this happens, which denotes that if patient enters into sepsis, the mortality has been estimated to be more than 10% if the sepsis is there, but if there is a shock, the mortality is around 40%. Previously, we used to be terminology called as SIRS, which is called a systemic inflammatory response syndrome, which is now an obsolete, which is not being used nowadays. So still, for knowledge purpose, you need to know what it used to include. It used to include 4 components. One is temperature, heart rate, tachypnea, and white cell count. So temperature, anything less than 36 or more than 38 comes under the temperature criteria. Heart rate of more than 90. Tachypnea, which is respiratory system rate more than 20, or PaC2 of less than 32, or white blood cell count, which is less than 4,000 or more than 12,000. So if anything out of these 4, if there is 2 criteria, it used to fit under SIRS. So previously there was another terminology called as sepsis, severe sepsis, septic shock, and multi-organ dysfunction syndrome. So sepsis initially used to be called as any patient with a confirmed infection with SIRS criteria was come under sepsis. Severe sepsis is that if there is sepsis with organ dysfunction, it was called as severe sepsis. So here there is no organ dysfunction, there is only evidence of infection. Septic shock is with patient with refractory hypotension, and multiple organ dysfunction syndrome, which is evidence of more than 2 organs being failing. So now the criteria has been completely changed, and the new definition has changed it actually. So now there is nothing called, there is sepsis, severe sepsis, and septic shock has been replaced with infection, sepsis, and septic shock. So what does that mean is that now if there is only evidence of infection, then it is called as only infection. Sepsis is called only for patient to call to be in sepsis, there should be definitely an organ dysfunction. So this severe sepsis terminology has been removed now. This has been replaced with sepsis. This has called as infection, and this is called as septic shock. So there is another priority called as another terminology like quick SOFA score. So quick SOFA score. Quick SOFA variable, which includes rapid assessment of an infected patient likely to have sepsis. So because this SOFA score is actually very much complicated, it includes a lot of component, so may not be assessed very quickly. It takes time to assess this. So there has been a quick SOFA variable which has been made, which includes 3 components. That is altered mental status, BP of less than 100, or respiratory rate of more than 22. So BP, altered mental status, in that, and if there is 2 out of these 3 criteria, there is called, this is indicative of poor prognosis. SOFA score, hypotension, altered mental status, and tachypnea. So out of these 3, 2 indicate severe poor prognosis. Pathophysiology wise of sepsis, as we are told, infection enters the body, which is actually called as pathogen associated molecular patterns. So whenever infection enters, our body detects it by some receptors on the innate system, that is called as pattern recognition receptors. So this receptors not only recognizes it not only recognizes only infection, it also recognizes host cell, and thus there is damage to the cells, normal cells as well, and then it is called as damage associated molecular patterns. So whenever there is damage, it occurs. This induces immunity, which leads to release of inflammatory mediators like TNF alpha interleukins. So what happens is that all these things will include both pro-inflammatory and anti-inflammatory. So normally in healthy patients or anyone, there's balance between this pro-inflammatory, that is the one which is going to cause more inflammation, and there is anti-inflammatory system which will try to control the inflammation so that it doesn't damage the normal healthy cell. In sepsis, due to some reasons, there is a exaggerated inflammatory response, and there is misbalance between this pro and anti-inflammatory, and thus leading to organ damage. Etiology wise, the most commonly 80% is mainly due to community acquired, and the most common site involved based on the studies which we have seen is lungs. Its majority of infection is because of the lungs in 65% case, and in rest is second is abdomen. And also the SOAP study has revealed that previously it used to for sepsis to be common only like gram positive cocci or gram negative bacilli are actually found to be equally prevalent. So there is nothing like only gram negative cocci or gram positive cocci which is responsible for infection. It can be equally involved. And the most common organism which is found to be Staph aureus, E. coli, and Pseudomonas. What are the generalized risk factors for prone? These are the patients who are more prone for getting infection converting into sepsis. That is extremes of age, like very elderly patients or newborn babies or patients on immunosuppression are more prone to get infections. What are the risk factors for bloodstream infection? So, any patient to get a bloodstream infection or a infection in the blood, if presence of indwelling catheters like central line or patients who are on parenteral nutrition are more prone to get bloodstream infection. Chest infection, patients extremes of age, immunosuppression, patient may can aspirate, so aspiration pneumonia, so we have to be careful to prevent that aspiration. Patient of COPD, patient who are on prolonged intubation. So in that intubation, that endotracheal tube itself can be a source of infection and where infection can accumulate, or patient who have undergone thoracic surgeries. Risk factors for UTI. UTI is patient who is on indwelling catheters, females and poor mobility who are bedridden or more chances of getting into urinary tract infections. Diagnosis, what we need to do, we do a simple workup of any patient suspected of sepsis with a routine blood count, which may show leukocytosis or leukopenia. So both can be suggestive of sepsis, or a normal WBC count, but if it shows more than 10% of immature forms. So immature forms are more, that means that the bone marrow is trying to compensate with the formation of more WBC to fight the infection. So there can be more than 10% of immature forms. Hyperglycemia, as sepsis itself is a serious condition, so body tries to fight with it. So fighting with that, we have a hormone in our body called as adrenaline or corticosteroid. These steroids are responsible for increasing sugars, despite even the patient is patient is not a diabetic, patient may present with hyperglycemia because of increased steroid response to fight infection. And plasma CRP, which is more than 2 times above the normal value, or arterial hypoxia, which can be assessed by ABG. Also, a patient of sepsis, because of this, what happens, there is a vasodilatory effect, or the peripheral vascular system is affected with sepsis. So sepsis leads to vasoconstriction and all, or like peripheral vasodilation pooling, and thus there's no vasoconstriction, there's peripheral vasodilation, and thus the perfusion, what happens is urinary perfusion to kidneys are decreased, and thus leads to oliguria. Okay, or creatinine increase of more than 0.5. Coagulation abnormalities, thrombocytopenia, which is platelets of less than 1 lakh, can be seen in patients of sepsis, hyperbilirubinemia, and adrenal insufficiency. So lactate. So many times we may have seen a patient who has been treated with sepsis and lactate is being asked for. So single lactate actually indicates a patient with hypoperfusion. So what happens is that our body or cell initially uses oxygen to generate energy, but once this oxygen has decreased, because if there is a hypoperfusion, because of decrease of flow to the any organ or anything, so what will happen is that the cell, after the aerobic oxygenation is used, now there is no oxygen left, so it starts using anaerobic metabolism. So anaerobic metabolism generates end product, uses glucose, and the end product is lactate. So if more the lactate value, it means more the hypoperfusion and more chances of more the hypoperfusion and more uses of anaerobic metabolism. So that can be indirectly marker of a sepsis. So what they have said that if a serum lactate level is more than 4, it is consistent with, but it's not diagnostic of septic shock. And single lactate value is not of much significance. Basically, lactates are used to monitor treatment. So if you're monitoring treatment, you're started a treatment for sepsis. And if you're taking sequential lactate levels, so 1 day, 2nd day, and 3rd day, and if your sequential lactate levels are decreasing, in decreasing trends, that is considered to have a very good prognosis. So whenever needed, based on the, you take any patient with sepsis, you take a history, and if you suspect any other system to be involved, like if you suspect pneumonia to be involved or lungs to be exposed, you ask for chest X-ray. If you think abdomen is involved, then you can ask for ultrasound and also radiological evaluation depends upon the symptoms. And nowadays we use plasma procalcitonin, which is an indicator of bacterial infection in sepsis. So management of a patient with sepsis. So first is patients with sepsis, because of this, they are actually in hemodynamic unstable, which is indicated by what is called as hypotension. So they have hypotension, that is systolic blood pressure less than 90, or MAP of more less than 70, or elevated lactate of more than 2. So in this patient, what you need to do is immediately you should start in them on IV fluids, and most commonly which you should crystallite fluids. The crystallite fluids are good for volume loading, where we give at a dose of 30 ml per kg of dose, which has to be initiated within first hour. It has been seen that colloids are more expensive, and then multiple studies have showed no difference between crystalloids and colloids. Because theoretically, you might feel that you are giving a colloid, it will stay more in the circulation, and that will increase the BP. But the studies have shown no difference, and moreover, the colloids are very expensive and can cause nephrotoxicity. So, except albumin, none other colloids has to be used in case of sepsis. And this has been seen that when compared to normal saline, ringer lactate is a better solution. Source control. Source control is the removal of infected tissue. So in any infection or sepsis, the source control is the most important. Like if you find a source of sepsis, or like if there is an abscess or anything which has formed in the body or somewhere, so no matter how much ever of antibiotics you may give or fluids you may give, but if you do not remove that abscess or the source of infection, if you do not control it, the infection will keep on spreading. So it is considered as the best practice in the management of sepsis. So antibiotics should be started within 1 hour of sepsis diagnosis. Once you have suspected a patient with sepsis, you should start antibiotic immediately after taking cultures. So what I have seen that if you delay starting antibiotics by more than 1 hour, there's been seen that there is 7% increase in risk of death for every hour of delay. So if you delay by each hour, there can be chances of death by increases by 7%. So initially, because we do not have a culture reports, we start empirically with a broad spectrum antimicrobial therapy, and based on the culture reports and the response, we de-escalate based on day by day assessment. So vasoactivation after fluid resuscitation with crystalloids or ringer lactate, if the BP doesn't come back to normal, we may have to use some vasoactive agent, because the target we should maintain is MAP, which is mean arterial pressure of 65 you have to maintain. And this is sufficient, and many studies have shown that maintaining of higher MAP hasn't found to be doesn't show any much evidence or benefit. And only thing where we maintain a higher MAP is patients with history of chronic hypertension or who are developing acute kidney injury. So two things to assess that the patient is hemodynamically stable or not is first is to monitor BP. More than BP is mean arterial pressure is important. And second thing is renal perfusion has to be measured by measuring urine output. If any patient passes more than 0.5 ml per kg per hour, ml per kg per hour, it is assessed that the patient is very much well perfused, and we can continue with the same treatment. So if at all we have to use vasoactive agents, most commonly we use is norepinephrine, which is the preferred first-line vasopressor. Cardiac dysfunction. Many times it has been seen that patients with sepsis are prone to get myocardial dysfunction. This is called as sometimes many of the echoes, if you see, they may mention you as a global hypokinesia. So sepsis itself can damage a heart, which is reversible. Like if when the sepsis is controlled, the heart myocardium may also again contract normally. So myocardial dysfunction has been seen. So many of the time we may have to add some inotropic agents. But what they say is, based on many studies, only if the cardiac dysfunction is proven, like echocardiogram showing some LV dysfunction, then you start with inotropic, or routine use of inotropic agent is highly discouraged. Glycemic control. So what is the target sugar we have to maintain is less than 180. They have seen that maintaining of tight glycemic control hasn't shown to be of much benefit, but has increased the risk of hypoglycemia. So target should be to maintain sugars less than 180 for a better infection control. Nutritional support. One study has shown that enteral feeding, like passing of Rile's tube or oral intake of food, compared with parenteral route in ventilated patients, was associated with greater risk of gastrointestinal complications. Because what happens in during the sepsis or issue or blood or arteries and all tries to direct blood to the organs which are very much required, like heart, kidneys, and brain. They are trying to preserve that organs initially. So there is decreased flow to the GI system. So if you give enteral feeding, what will happen now is that your intestines and all also need blood supply for proper absorption of the food, or for intestines to work, they need a proper blood supply. So if a patient is in shock, there is decreased supply to the GI system, and if you're giving enteral food, so the intestines may not be able to like when they start, they need more work and they need more blood supply. Since blood supply is not matching to the demand, there can be leading to GI ischemia. Steroids in sepsis use is very much controversial, and ESC guidelines has shown that only use of steroids has to be only considered when you have tried all the measures to prevent such shock. Like you have, for shock, you have given IV fluids, or you have given patient put on vasopressins or noradrenaline. But despite of that, if patient shock is not improving, BP is not improving, you may trial with corticosteroids. Otherwise, routine usage of steroids should not be used. One study called as Arterial multi-center study was negative for its primary outcome, but they have showed that mortality, there is no mortality benefit, but showed shorter duration of shock and ICU stay in the glucocorticoid group. In the other group, they have seen that combination of hydrocorticoid and fluorocortisone was associated with a low all-cause 90-day mortality, but still the use is still controversial. Few studies being showing some benefit, few studies not showing much benefit, but overall there has been no benefit in the mortality as such. Hemoglobin target, blood transfusion has to be given only if the hemoglobin is less than 7 grams per deciliter. In the absence of ischemic heart disease, if the patient is known to have ischemic heart disease, the target goal should be more than 8 grams of hemoglobin. Arterial oxygen saturation, as various studies have shown that a patient who has been maintained saturation of around 97 to 100% has found to have worse survival rates when compared to patients who have been managed with lower target range, that is 94 to 98. So this is important. Many of time we may have seen patients being giving a full oxygen or giving a lot of oxygen being given to patient even without evidence of hypoxemia. So what happens that if you give too much of oxygen, so when whatever the oxygen is required, our body will use the remaining extra oxygen which you are giving to this 100%. So this extra oxygen will react and form free radicals. This free radicals is not good for her body. Free radicals will keep damaging each and every cell. They may do endothelial damage, they may damage the myocardium, they may damage the brain tissue. So that's why that it is always recommended to target to a lower one, that is 94 to 98%, and never try to target up to 100% of oxygenation. So take home message in this, that measure lactate levels and remeasure if initial lactate is more than 2. So single reading has no much value. You should remeasure, and sequential values has to be taken, and obtain a blood cultures. So prior to administration of antibiotics, it's always better to take blood cultures, because then we know what infection we are dealing with properly. Because if we take cultures after we give antibiotics, we may not get a proper results. And administer broad spectrum antibiotics initially. You should not start with the basic antibiotics. You should start with broad spectrum, and based on the response, you can then de-escalate, and depending on the blood cultures report as well. And as soon as you see a patient with shock hypotension, you should rapidly administer 30 ml per kg of bolus of crystalloid, and apply vasopressors. If the MAP is less than 65, you have to add vasopressors. The preferential one will be noradrenaline, and maintain sugars at less than 180 milligrams per deciliter. Hope you have liked my video. If you have liked my video, please subscribe, like, and share with your friends. And do subscribe to my YouTube channel, Dr. Akif Baig, for more interesting videos. If you have any other doubt in this topic, do let me know in my comment box. Thank you.